Pelvic injuries. Pelvic fracture typically occur in patients who have suffered high-energy trauma. The fracture is often associated with other injuries. Priorities in the initial management are similar to those for multiple trauma. Severe pelvic fractures can be associated with high suffered rate from severe intrapelvic bleeding and also from the associated injuries. Severe bleeding results primarily from laceration of pelvic veins, although arterial bleeding also occurs. Injuries specifically associated with pelvic fracture include those of the neurologic, urologic, gynecologic, and gastrointestinal system. Local injury to the skin of subcutaneous tissue and also common. Contrast or severe bleeding associated with fracture in the primary initial consent. The severity of bleeding is highest is displayed and unstable disruptions of the posterior pelvic ring. Therapeutic measures for control of pelvic hemorrhage include intravenous crystalloid solution and whole blood, internal fixation of pelvic ring, external fixation of the pelvic ring, angiography, typically followed by transarterial embolization, and possible by repair of major blood vessels, and use of military anti-shock thousand mass suit. Internal fixation. Internal fixation may be used in some cases during the acute phase. A good indication for anterior plate fixation is a dislocated symphysis pubis and either intra-abdominal, intrapelvic, visceral trauma requiring surgical repair. Because internal fixation is much more effective in reducing and stabilizing the disrupted pelvic ring, it may ultimately have a role in the initial management of the patient with intrapelvic blood loss. However, at present, this remains controversial and experimental. applied to the anterior portion of both iliac crests. Many simple frame configuration provide adequate initial stability. With practice, the pins can be successfully placed through stab wounds along the iliac crest. External fixation is most effective in unstable fracture, then increase the volume of the pelvic ring, such as injuries in women, avoid separation of the symphysis pubis. External fixation doesn't control vertical translation of the pelvic ring, nor does it truly immobilize the fracture site. External fixation can increase the risk of infection if later open adduction of the pelvis is contemplated. It can also provide an avenue for bacteria to invade subcutaneous hematomas that may be present after the injury. External fixation is not indicated for the initial management of patients with acetabulum fracture. Treatment. Protein fragments are difficult to stabilize without external fixation. Crystalloid solution and whole bath. Resuscitation with crystalloid solution and whole blood is sufficient in most stable pelvic fractures. Stable pelvic fractures do not involve a significant disruption of the posterior pelvic ring. The initial displacement of the bone fragments is less. The addition of external fixation usually does little to control pelvic volume or enhance stability. Many unstable pelvic fracture can be managed by fluid resuscitation of the initial phase. The radiographic appearance alone, however, doesn't always indicate to surgeon which patient can be managed with fluid resuscitation alone. One possible cause in to monitor the patient, assessing to their response to fluid resuscitation. If there is a problem with continued blood loss, other hemorrhagic control measures can be undertaken. Angiography. If fluid resuscitation and external fixation fail, the surgeon should proceed to selective angiography. Although most bleeding is of venous origin, there are often small arterial bleeders that can be treated by angiographic embolization. The angiography should be localized as much as possible to the bleeding site to prevent aggravation of the circulatory injury. If angiography shows injury to major arteries of the pelvis, direct surgical repair is indicated. Angiographic embolization should not be performed unless there is good evidence that the patient's condition is unstable and a significant bleeding site has been identified. Adequate vascularization of muscle tissue with good collateral circulation is important if later surgical approaches to the pelvis or acetabulum for internal fixation are performed. The massage can be effective in controlling hemorrhage in unstable pelvic fractures. It can be applied by paramedical personnel and therefore serves as resuscitative measure before the patient reaches a hospital. The massage has some definite disadvantages, however, in that it prevents direct access to the patient for examination. It also prevents application of an internal fixation. It may mask and complicate associated injury to the lower extremities, such as open fractures, vascular injury, or compartment syndrome. Fracture of the pubic and ischial rami in the elbow are often caused by a trivial fall. The fracture usually occur in pairs, and fractures of the ramus alone is the usual. The fracture can be identified clinically by screening the pelvis, and radiograph will confirm the diagnosis. Treatment can be by early mobilization within the limits of comfort, provided that there is no displacement. After 2 or 3 days rest in bed, the patient will usually be able to move comfortably in bed. and can then sit out of bed. After 7 to 10 days, they can walk with crutches completely within 6 weeks. The main function of the wing of the ileum is to provide a firm foundation for muscle attachment and protection for the pelvic contents. It isn't a part of the weight-bearing mechanism of the pelvis because it is above the hip joint. The wing of the ileum can be broken by direct trauma or by crushing injuries and is easily recognized by pain of the pelvic compression and bruising from damage to the glute. There is often considerable blood loss because the bone is covered on both sides by muscle. Loss of up to 3 units should be anticipated. Treatment. The pain of the fracture, like that of the pubis rami, can be expected to diminish after 2 or 3 days, and mobilization may then be permanent. Where the displaced fracture may need to be reduced and held with external fixation. Because the fracture doesn't interfere with the weight-bearing mechanism, the patient can walk more quickly, but movement of the trunk will be painful for up to 6 weeks. The direct sideways blow to the great trochanter will drive the femoral head against the floor of the acetabulum and fracture the weight-bearing surface of the joint. If the fracture undisplaced, a good result is likely, but care must to be taken not to allow the fracture to displace by immobilizing the patient too soon. If the acetabulum is seriously disrupted and the hip joint badly damaged, management is more difficult and a good result cannot be ensured. Blood loss may also be considerable if the iliac vessels are damaged, and a loss of 3 units of blood should be anticipated. Treatment. Treatment depends upon the degree of displacement of the age of the patient. Undisplaced fracture. Undisplaced fracture. Undisplaced fracture can be treated by rest for 2 or 3 weeks, followed by caution, weight bearing with crutches for further 8 weeks. The fracture position may slip after an early good result, and regular radiographs are needed. If the fragments are displaced, the choice of the management depends on the patient. If the patient is our 50 years old and the hip joint is destroyed, traction can be applied and the hip movement begun at once to achieve the best possible range of movement. Osteoarthritis is inevitable, but total hip replacement can be considered in this age group. In the younger patient with displaced fracture, open reduction and internal fixation of the better long-term result, but this is a difficult operation of the perfection cannot be ensured. The acetabulum has 2 structure columns, one at the front and one at the back. In violent pelvic injuries, accompanied by twisting, the fracture line usually passes through one of the columns rather than through the floor of the acetabulum. Complete radiograph investigation of the pelvic fracture, therefore, includes radiographs of the pelvic taken at the 45-degree oblique angle to show up the anterior and posterior columns. Anterior, posterior, and lateral radiographs alone are inadequate. CT scanning or MRI defines the fracture line expectly. Treatment. Some fractures need open reduction and internal fixation. The decision depends on the pattern of the fracture. The severe crushing injury may disrupt the pubic symphysis, so the 2 halves of the pelvic open like a book. Symphyseal diastasis is hard to treat, and the soft tissue of the symphysis don't unite as soundly as bone. Complication. Non-union can occur producing instability of the pelvis on weight bearing, and there may be associated damage to the bladder and urethra. Treatment. Treatment consists of holding the two halves the pelvis together with a thin or external fixation. Internal fixation is possible, difficult and less satisfactory than internal fixation. Floating segment. If the pelvis take a direct blow from the front for pubic ring, may be damaged, leaving a mobile central segment to which is attached the bladder and urethra. Urological problems are usual. Urologic injury. Urologic injury in the form of injury to the bladder and urethra is common is pelvic fracture. The treatment is extraperitoneal bladder rupture is controversial among urologists. Some advocate a primary repair of the bladder, and the other advocate treatment with a follow catheter of superpubis drainage. Вот, Александр, я записываю английский. A patient with a pelvic fracture that requires internal fixation of the pelvic ring is best served by surgical repair to the bladder rupture. Urine from in unrepaired bladder contaminated by bacteria after catheter is introduced freely communicates with a dislocated symphysis pubis or anterior pelvis ring or acetabulum fracture site. Once a suprapubic catheter has been introduced, it becomes dangerous to approach an anterior pelvis ring fracture site for the purpose of internal fixation because of infection. In the case of a bladder rupture associated with a dislocation of the symphysis pubis, the best initial course is to repair the bladder surgically and to perform plate fixation of the symphysis pubis. Urologists may then proceed with postoperative follow catheterization or suprapubic bladder drainage. In the case of the bladder rupture associated with an acetabular fracture, the bladder rupture should also by repair initially. If the acetabular fracture is complex and requires a subsequent ileoinguinal approach, it is best to avoid damage through a suprapubic catheter and provide drainage through a Foley catheter. Although this increases the risk of peripheral fracture and infected hip joint after contamination of ileoinguinal approach by suprapubic catheter is a devastating and lifelong problem for the patient. Disruption of the membranous urethra must always be made by a suprapubic catheter, and urethra injury is best diagnosed by a dynamic retrograde uterogram. This should be performed in patient with pelvic fracture before a urethral catheter and is inserted because the catheter can aggravate a urethral tear. Any dislocation of the symphysis pubis should be played initially at the time of the suprapubic catheter insertion, because the catheter will be needed for several months, and percutaneous for definitive surgical reduction would otherwise be lost. This surgical approach to a fractured acetabulum may have to be modified accordingly. In any event, the orthopedic surgeon should advise urologists about placement of a suprapubic catheter or drain in the abdomen that might hinder the later internal fixation procedure. Posterior dislocation of the hip. Posterior dislocation of the hip is common in head-on road traffic accidents in which the hip and knee are both flexed. The fracture should be suspected in my patient involved in such an injury. The impact and transmitted via the patellofemoral joint, femur, and hip joint to posteriorly of the acetabulum, which is a thin bone and not designed for such impact. The injury often associated with fracture of the patella or the patella, rupture of the posterior cruciate ligament, and fracture of the femur. Until the dislocation is reduced, the femoral head lies behind the pelvis and the leg is internally rotated and shortened. There are also the segmental or slice fracture of the femoral head. The fragment may become jammed in the hip joint and prevent reduction or loss. The sciatic nerve may be caught between the femoral head fragment and damaged when the hip is reduced. Complication. Posterior dislocation of the hip has a high incidence of complications damage of the sciatic nerve, the lateral part of the sciatic nerve, responsible for dorsiflexion of the foot, lies immediately behind the hip and is often damaged in posterior fracture dislocation. Aseptic necrosis of the femoral head. Aseptic necrosis of the femoral head occur in about 20% of patients with this injury, but the incidence is less of the hip is reduced soon after injury. Aseptic necrosis may not be apparent until 2 years or in exceptional cases 8 years later. This is important when the assessing the long-term prognosis of the injury necessary for legal causes if the fracture occurred in a road traffic accident. Osteoarthritis. If the femoral head has been damaged or there is aseptic necrosis, osteoarthritis is almost inevitable. Ectopic ossification can occur around his dislocated hip, reducing joint movement or causing pain. The dislocation should be reduced as soon as possible. Reduction is usually easy, but be careful if there is an associated fracture of the femoral head or neurological damage. Always record the neurological function before and after reduction. If reduction isn't easy, open abduction is needed to avoid damage to the sciatic nerve. Definitive management depends on the stability of the reduction. If the hip is stable and the acetabular fragment is small, bed rest for 2 or 3 weeks with early mobilization is sufficient. If the fracture is unstable but the fragments are in good position, bed rest for 6 or 8 weeks is advisable. If there is a large single fragment or a fragment poor position and the hip is unstable, the fragment should be replaced and internal fixed.